So it's been a pleasure over these past few days meeting with you and getting your feedback and hearing from you about your experiences as a Carequality Connection. So what we're going to do now is, speaking of feedback, we're going to get that from these three esteemed members of this panel. I'm going to briefly introduce them and just ask for their experiences. So first, Dr. Matthew Eisenberg, if you can introduce yourself and tell us a little bit about your org and your experiences.
Sure. Can you guys hear me? We're good? Fantastic. Good morning. So I'm Matt Eisenberg. I'm currently Associate Chief Medical Information Officer at Stanford Healthcare. Stanford Healthcare is part of Stanford Medicine. We're based on the Stanford University campus. We have a three-part mission around care, discovery, and education. As a system, we're a small hospital platform, 2 hospitals, about 800 beds. So really, actually, in this day and age, pretty small, but we do almost 2 million ambulatory visits, and we cover all of the San Francisco Bay Area in many ways. Now we have sites in the East Bay, San Jose, Los Gatos area. I focus on interoperability as well as regulatory reporting, promoting interoperability. I can't say meaningful use anymore. I have to stop saying that. And we have some really, do you want just that about me or a little bit more about our exchange goals? Let me do that. How's that? And then I'll turn it over.
Okay.
So at Stanford, we've actually had some set up goals about exchange. We want to do it all the time at every touch. That's been our plan. We really want to educate particularly our health consumers, our patients, about the value of health information exchange. And it was really important when we moved to a default opt-in model, which was really important. We leverage standards. This is all about leveraging standards. We really tried not to just do everything one-off or point-to-point. That's going to drive us crazy, and it's very expensive. It's all about the workflow. We want an integrated workflow. And then the last 2 pieces are we really want to work regionally and nationally, which is why I'm here. It's why we're here, I think. And we'd like to be a leader in the space. So that's a little bit about Stanford Healthcare.
And next is Melinda Brown.
Hi, thank you for inviting me. Melinda Brown. I am a IT manager at Wellstar Health Systems in Atlanta, Georgia. We formed our interoperability team about 4 years ago, and it's been a journey. Bringing our providers and patients and leaders to the understanding of what interoperability really means and how do we utilize it. We have 11 hospitals. We have over 250 primary ambulatory practices and 4 urgent care centers and 4 health parks. So we're growing and growing and growing, but it's exciting to see the change of interoperability and how Carequality has helped us along the way in sharing our information with other trading partners. So.
All right, thank you for that. And Caroline, can you go next? Briefly introduce yourself and tell us a little bit about your experiences.
Sure. I'm Carolyn Brozak, and I'm from DC. Okay, is this better? I'm Carolyn Brozak, and I'm from DC. I'm with Children's National Medical Center, and I run the Children's Integrated Quality Network, which is a pediatric health exchange. We started many years ago with a vision of our CMIO. The Children's Integrated Quality Network, we call it CIQN, is a network of roughly 75 practices, primary care practices, 1 urgent care center, and it represents about 400 providers. And we started out with the electronic health exchange with eClinicalWorks and connected Cerner and eClinicalWorks. From there, it's expanded, and now we focus on interoperability basically everywhere with everyone. And it's, again, getting all the information to the primary care physicians so they can focus on their medical homes, and they can focus on everything else, their meaningful use, and all that. So.
Okay, great.
I would like to know what EHR system each one of you are using in your facilities.
We're using Epic.
And they're using Epic. We're also an Epic shop. We are Epic. We use Epic.
Okay, so
Yeah.
two epics?
And Children's is Cerner, so it's, and the CIQN is eClinicalWorks, and we also connect with Epic and Greenway are also two main users. So.
Okay, thanks, that helps a lot.
Okay. So next, I was wondering if each of you can speak to what positive impacts you've seen for your providers and maybe how it's helped to improve some patient outcomes.
Well, you want me to start?
Matt,
Go
you
for
can
it.
Okay. Well, with Bill, we've been practicing for several hours. Actually, we had 4 minutes before we started, but I think we're good. We were actually able to come up with the key points in about 4 seconds. So we're an Epic shop, and sort of set things back a little bit, right? So forgive me if I'm redundant for those of us who've stayed the whole week and we're here on Wednesday, but I've set this up as sort of the 3 V's and the 3 R's in terms of, think about virtual reality, or V's and R's. So for us, it was about vicinity, volume, and value. So when we started, we had access to other Epic sites through the Epic network. We call it the Care Everywhere network. It's now about 370 sites. We joined the eHealth Exchange because we wanted access to non-Epic sites that we could exchange with, particularly federal partners. Big push to the VA. There's the Palo Alto VA Hospital is about 2 miles from our hospital. We share a lot of patients. VA, Dignity Health System was on the eHealth Exchange, large system in our area. We were involved with them. We joined the SSA, and several California regional health information exchanges were also on the eHealth Exchange. So we were early adopters of the eHealth Exchange. I mentioned on Wednesday it took us a little while to get legal and compliance. I referred to that as a brief case of Dursitis, for those of you familiar with the Dursa. It's a good joke, I'm the only one that's the Dursitis problem. The real key for us, so we were early adopters of 2 things, Carequality, because it was the last mile for us. It got us into all of those other networks that we could not access through those other connections using standards and baked into our workflow like I talked about. So it would be seamless for our providers. That was really the key. And we wanted access to a record locator service beyond what we already had through our technology. So we were early adopters of the SureScripts record locator service as well, because we had tried to automate query wherever we went, and we wanted SureScripts to help us. So for us, Carequality was about just extending the technology in a broader way.
Yeah. Similar story. We were early adopters of Carequality also. Back in 2014, one of our IT VPs reached out to me. He said, there's this thing out there that says it can connect different EHRs together, and it's a beautiful thing, so you really should jump on board. So I went in full force and have learned a great deal in connecting with other EHR systems. I think we've got a long ways to go, but I have seen the beauty of it, come about with our physicians, because like Matt said, we want it to be seamless. We want the providers just to have that information readily available at that point of care, or even prior to that point of care. So we had the opt-in, let's just share information with everyone. We have noticed that we've had some struggles with other EHRs and them adopting that method as well. But we've got over 47 million records received in the past 4 years. So it's exciting to see when a patient presents themselves at the point of care and we already have their information available. And they are starting to also demand that, or they'll go to another organization if they can't have all of that, their patient record, readily available at that point of care. So great outcomes. Excited to see where we're going to go in the future with it.
Okay, great. Do you have anything to add?
Sure, a little bit. We actually are a little late adopters to Carequality, just really pushing putting a big push on it in the last year. As I said before, we started out as a pediatric health information exchange, just connected to children's, a small Epic provider, and then so basically Cerner and eClinicalWorks. And so that was able to get the providers the information and get their primary care information to the specialists, et cetera, all locally. If they went outside the system, that became a problem of getting the information back in. So now what it's allowed us to do is that provider who's just used to just getting the children's information to be able to expand to other inpatient hospitals in the area. And I guess this is like a small example, but it's made a huge impact. Again, we're pediatrics, so just the biggest excitement I hear over this is the pediatrician in their office being able to get the newborn records and newborn screening tests from the hospital, from the newborn, because very seldom are finding that the 2-week-old visit actually has the information, they need, et cetera. And again, the NICU patients, et cetera. So the primary care physicians are so excited just to be able to get that information in their office so they have it when the newborn shows.
Okay, great. So next I'd like to ask, what advice do you have for other folks in the room who are looking to optimize their Carequality connection?
Just, if you're not doing it, just get started.
Yeah.
It's not that hard.
Share everything and educate too. Educate, because we had a big issue, and again, we have over 300 primary care physicians, and none of them are employed by us. We just have a contract basically with them to share information. So their point of knowledge of interoperability and the value of interoperability is very broad. So we have some that are all in all the time, and some that are so reluctant, and then all of a sudden the light bulb comes off. So education for us has been a big thing with not everybody, but we found that education with some of the smaller practices is very important.
Yeah, I'll piggyback on that. Education is key, and getting that information out to the smaller practices, because it's getting to the right person in that smaller practice too. Struggles with finding the right person that can, talk to their EHR vendor and, have them understand that Carequality can benefit them greatly was just, I'd get, the deer in headlights look when I went to go talk to these practices. But if I start to actually show them the benefits of it, they're on board just like that. So I would say really work with your community physicians, work with trading partners, and work with other vendors to get it going.
Yeah, I would add, this is really critical, and we did some work here. So we do interoperability every day. We're thinking about this every day, and when you say Carequality, we know about it. A lot of the small offices don't. They don't know what direct is. And we worked cross-implementer, which really was important. We're an Epic shop, but we needed to know who the Athena, who is the Athena works person, who is the clinical works person, and we put together contact lists for a lot of our local practices and said, you're an Athena shop. Here's the person you need to give a call. If they haven't contacted you, please get on board. We want you on board, and that would be helpful. So that outreach, particularly because it's usually through provider referral services, it's a different group of folks than the folks who come to this meeting. Go out, talk to them, put together some information for your local practices. Say, here are your implementers. It's, you don't even need to know what this is. But these people are exchanging as part of the Carequality Framework. You're already in the party. You just need to show up and have fun.
Yep, turn it on.
Great. So what I'd like to next talk about, this is all great stuff, but I'd like to hear some of the struggles and challenges that you faced and how you overcame them, and maybe that will help others who are faced with similar struggles and or challenges. So if there's a story you can share that can hammer that point home, that would be great.
I have lots of stories. I think the biggest key with struggles was having the providers understand the amount of information that was at their fingertips. But then they were starting to see duplicate data because we were connecting with so many different trading partners and using Carequality. It brought in that duplicative data, and they were getting pretty frustrated with it. We are still working on that and seeing how we can consolidate a lot of that data for the providers because they were spending a lot of time going through the same information, same meds, same allergies, same problem list, and working on trying to reconcile that better. So that was one of the biggest ones. And I think, again, going back to working with our affiliated physicians, I had a provider call me on a Saturday morning, 7 a.m., and he was new to the practice. We just acquired the 5 new hospitals this past April and brought them up on Epic. Well, he practices inside the hospital, and he has Allscripts in his practice. He says, I'm having to leave the hospital, go to my practice, print out my patient records, and bring them back to the hospital. My mouth dropped. I'm like, you've got to be kidding me this day and age. So I feel like as an organization, we're here, but everybody else is still, way down here. So it's bringing them back and sharing, that capability of getting that information and being able to help them. So lots of fun challenges.
So we had also talked, initially there was some technical challenges we had with Carequality, in that every time a new connection would come on, we had to manually put them into the system somehow. And we've talked about this. We're fortunate. Our vendor helps us now automate as new practices come into Athena Health or into eClinicalWorks or onto the NextGen platform. The directory is now getting automatically updated. So the directory management's always a problem, right? It's a problem for all of us. Automating directory management's been a great technical help. The problems we have with Exchange are the problems we have with Exchange for all Exchange. And I mentioned those Wednesday as the 3 R's, which is relevance, reconciliation, because now there's so much duplicate data, and readability, usability. We've talked about this before. Content that's meaningful for that provider and patient at that encounter for that purpose. Something you can find as opposed to going through blocks and blocks and blocks of useless CCD information. Up-to-date information that is reconciled. Those things are ubiquitous within the HIE world. I think we're working to try to solve those. Carequality helps us get that extra mile, but we still have a lot of work to do in that regard.
And I would echo the same. Duplication and usefulness. They generally don't find the CCD as useful, and that's where showing them, which was easy in our case because we have so many primary care pediatricians, what can be useful, where you're able to find it, et cetera.
Yeah,
duplication is the biggest.
The biggest problem right now is reconciling data. And, because it's, patients can't even curate their record from 15 different places. We are all seeing different providers in different places. That's very hard to do. We need technology that's better at that. The good news is we're getting the data. The bad news now is we have so much data that has to be reconciled. We need some technical help to do that. We need to do it based on most recent timeliness. It needs to be sortable. It needs to be semantically interoperable so people can actually understand what it is and put it in the right place in the chart at the right time. We're getting there, but we've got a lot of work to do. I just want to add, I forgot to mention, outcomes. We've talked about outcomes. I don't have any specific story where it saved us from doing an extra imaging test that it wasn't necessary. I'm sure that's happened. For our providers, whether it's Carequality or it's an Epic shop, a record is a record is a record. They want access to the right information. We see a lot of viewing in our ED and our inpatient side, and specifically certain areas. New patients, obviously, referrals that are complex. But we have information about volume. So we've been seeing 28,000 records shared between Athena Health and Stanford Healthcare, 85,000 with NextGen. A lot of local practices that have come on board, for them it's been great. That last mile piece is important because we had to get them either onto a provider portal or some other way. But again, now on their end, the information's available to them and the information's available to us. So that expectation that the healthcare is seamless to the patient, to the consumer, is something that we can really extend. I think that's what the magic of Carequality is. That's why when they say half of the country's on Carequality, like, get going. Let's get the second half.
Right, absolutely. So I was wondering if you guys could next talk to us about what your personal goals are for the future of Carequality. What would you like to see? talk to me about your hopes and dreams, I guess we could say.
I'm not sure Carequality is part
No.
of my global hopes and dreams.
Nope.
I mean, I want to hear more
beach.
Dave Castle, but I can do that on the advisory council. So it's not a hopes and dreams thing, but
I would say fire. I want to see
Yeah.
some use cases with fire and being able to use Carequality to bring that information in through fire. We're looking for some use cases now. We've been slow to adopt fire, but we're turning it on in January. So looking for different ways to measure, like you said, the data that we're getting. We're getting it. It's great. Now, how are we measuring? How are we doing with this data and using the governance that we've got, with different initiatives?
Right. So coincidentally, there are work groups that are
Yeah.
forming right now for
Right.
fire, both technical and policy work groups.
Yes.
And we put out the call to arms, and we've gotten a bunch of volunteers for that. So we're definitely excited to continue to explore fire and how we can utilize that.
Yeah, I mean, look, we have one wonderful implementation guide that's being updated.
Yeah.
I think this came up earlier. So, the framework is an evolving framework. If you're Jewish, there's this Talmudic thing. The Bible keeps, it just keeps, there's this Talmudic idea that you bring to the basics, and it just keeps growing. It keeps evolving. So the implementation guide will be updated, but we need more implementation guides. We have the one. We'll need many, many more, and it's roll up your sleeves, because those take a lot of work.
Right. How are we doing on time? I do not have a watch.
One of the questions we were supposed to talk about is how we heard about Carequality. Do you want to talk about how we heard? Because I have a good story, but I want to hear how you heard about it.
How we heard about it? I think it's just basically our network and working with other hospitals. They came up, and I think it was Epic with Inova basically started it, and then everybody started talking about it. But it wasn't really a aha moment. Your story's probably better.
It might be.
Well, again, my VP, one of my IT VPs, was working with our Epic TS, and we were implementing the Care Everywhere module, and we got connected with the eHealth Exchange, started looking at regional HIEs to connect to, and all of this happened about the same time. So it was just a conglomerate of connections, and who do you want to connect with, and where's the most benefit from it. I was voluntold that I needed to get on the advisory council with Carequality, which I did promptly, and it has been a journey. I love hearing the stories, each month when we meet, and seeing how we've evolved with Carequality, and seeing how the data that we're exchanging with is changing, but the implementation guides that are coming out, the education that's coming out, has been so beneficial. So, lots of fun stories, but I'd have to say yours probably is much better than both of ours.
My story is, so TS in Epic speak is the technical support person, is the person that we get to help us. So for all of us who are on Epic, we have a technical support person. It's our primary person to contact for health information exchange, the Care Everywhere module, the tools, and how to use it. So my story is really about, in Breaking Bad, there's, you better call Saul. My story is go mob Rob. Where's Rob Klotwick? There's Rob Klotwick. Stand up, Rob. Go mob Rob. So Rob was my technical support person when I first started working with Epic in the HIE space at my previous employer. And we had developed this great relationship. And then I changed jobs. But I was fortunate enough to be voted in to the Epic Care Everywhere Governing Council. For those who don't know, the Epic network, the Epic Implementer Network, is self-governed by participants. We vote. We have now 15 members on the council, and it's co-led between Matt Doyle and Rob and others with participants who are voted onto the council to help improve interoperability, and advance interoperability at all of our individual sites and at a national level. And I think that's been an incredible experience. I've learned a ton. That's when they said, you need to know what Carequality is and go mob Rob, because he's the guy you need to talk to. Yeah. That's how maybe that wasn't the motto back then, but we walked through the process. So it was great for me because I got to reconnect with Rob in a different way. And I was in an opportunity because we were part of the governance group to try to help bring everybody up to speed as quickly as possible. And I think that's been very successful. I suspect there are other implementers who have similar stories.
Okay. So what are each of you doing internally to ensure success with the Carequality network and connections? And have you had to change any internal workflows or make any changes to your the way you do things?
I guess the biggest issue with us is education about consents and making sure everybody had appropriate consents and that their individual per office, their consents were the right language and they understood exactly what they're doing. So I go back to education, and it's hands-on education and really an ownership thing of wanting this to succeed.
Yeah, there's some unique challenges in the pediatric world in terms of consent, access, as well as patient matching, particularly in the newborn population, which there's been a lot of work. So if you're not familiar with some ways to try to improve, patient matching is hard enough. It's really hard if you're baby A. Jones, of triplets. So there's some standards that are starting to take root, which are very helpful.
I would say training again. Working with our care teams now with population health and closing care gaps. We've taught them that they can get this outside information from other trading partners, other organizations, to close a lot of those care gaps now. So training was key, and allowing them to query outside an encounter. So prior to the patient's visit, or not at that point of care, allowing them to get that information quickly. So there were some workflow changes that were made within the organization. Yeah.
Yeah, we're also focusing on population health, and where the data's there, trying to incorporate it discreetly so we can capture it for quality measurement purposes. I wish that was easier. One day perhaps it will be, but there's work there as well to do.
Yeah, we're doing the same and trying to bring it all into registry data.
Registries, care gaps, in the adult population health world, there's really a handful of important pieces of data that we would like to be able to discreetly capture and incorporate, and we're working on that.
Okay. So I was wondering if you guys can also speak to your interoperability landscape before you became a part of Carequality and how that looks now, and talk about those differences, and maybe your experiences exchanging with the partners.
Sure. Well, ours was pretty big. I mean, again, we've been exchanging data for a long time, as everybody here has, and it was great. I mean, we thought the connection between children's and the primary care physician, the specialist, was fantastic. But again, it's like kids aren't born in a children's hospital. Kids don't go to the ER at the children's hospital. They go to the ER in their community hospital. So it's pretty phenomenal once, again, a provider gets it, like the difference of just being able to exchange to children's and then being able to exchange with the whole area.
Okay.
I would say we had a lot of disparate HL7s with different organizations that we were receiving information from. And now that we've got Carequality, we're able to get that information by doing an auto query and getting batch results back from different organizations where we previously were using fax. So it's come a long ways.
Yeah, as I mentioned before, just expanding the reach, particularly into some of the clinics that we couldn't access before, is helpful. Moving away from the need to use a provider portal so it's available in both systems, that's been very helpful. The record locator service is helpful. We think that's been able to bring in more records from farther destinations. We're a referral center. We have a lot of students that are coming from health centers across the country. We want to be able to access those records, and we auto query within a certain region, but if it links up through SureScripts, there's a record at their previous university, we can pull those records if they're in our directory. So that's helped quite a bit, and I think that's made a big difference. For us, again, we really didn't want to break the workflow. We don't want to make more ADT feeds if we can avoid it, although more and more I think there's sort of a yin and yang about where you use that, where you don't use that, and how to push CCD exchange as a way to get that information back and forth. But we're making progress.
Okay, great. So we essentially started with a question from one of the audience members. I was wondering if we would like to extend that to anyone else in the audience. Does anyone else have a question they'd like to ask?
Jay, running for a mic to run for mics. And Bill? Well, I'll start, and I don't know how well we'll do it, but obviously there's been a challenge as we get more implementers that are in the post-acute care space, behavioral health care space. I think there's really an opportunity for us to connect to people that we otherwise we just can't reach. It's like, we're calling, but there's no phone on the other side. They don't have direct, they can't take a CCD. I think for us, it's going to be really important for us to sort of see how to leverage those extra areas that sort of got left out with the meaningful use dollars. I mean, obviously we've talked about that, but that's going to be a real challenge for us to leverage that in an effective way.
I would say allowing patients to exchange their data. I think having more awareness that patients do have access or can have access to their own data and able to exchange it. So putting it more in a patient's or a consumer's hands and being able to use Carequality to utilize to get that data to those patients. So.
Yeah, I was going to say the same thing as far as consumer ownership and being able to manage and own that data instead of the provider owning that data.
Yeah. I'm a big fan. I can pull my data out of my Epic system and view it on HealthKit through FHIR APIs, and I think that's great. But I'm also a little bit, we've talked about this. We're not going to replace CCD transfer overnight and query for records. Not going to happen. I mean, I think no matter how much you think you've caught fire, it's not going to replace the level of exchange we have overnight. Just not. We don't have the infrastructure for it. We don't have the technology. The tools aren't built. It's coming. I am a little concerned because I remember the days of Google Vault and Microsoft Health or whatever they were, Health Vault and Google Health or whatever. It's really hard enough for us to exchange and then reconcile, but to put the burden of curating your record back on the patients, that's been unsuccessful in some ways. I think there's opportunities, great opportunities there to do that, and if there are tools to help with that, that would be great, and I look forward to that. But I don't want to forget some of the challenges we've had in the past.
Checking. Okay, it's on. Question for you with regard to the exchange. It's primarily CCD exchange, but do you have particular workflows that you've done that have either started to parse discrete data out of that, or is the primary use case still doctors having multiple CCDs or an aggregated CCD that they're looking at from Carequality? Like, how are people using what gets retrieved in your respective systems?
I would say with Pop Health. So we are trying to work with different trading partners, different specialty groups that we know we can get the data from, using that to look to close care gaps, number one, but also using that data for hopefully predictive analytics and being able to treat those patients prior to them having specific diseases or that sort of thing. So I think working with Pop Health and getting that data, that discrete data, has given us more of an opportunity to utilize the pieces of that CCD, whereas before it was just, oh, this is great information, we've got allergies and meds, but now if we can get additional documents or tests or lab results, that sort of thing, we're looking at that now. I'm forming actually an interoperability group, a workforce group within our organization, but also working with other organizations, community physicians, to see how we can better utilize the data that we're exchanging.
The only thing I would add is we moved in our EHR to try to commingle a CCD with our native record. So when you go to the encounter section, you can see outside data with internal data. And we've always been able to, if we can get the data discretely for the 4, we call them the PAMIs, problem, allergies, meds, and immunizations, we'll offer opportunities in the workflow to reconcile those. Again, for new patients, that's fantastic, because you get a med list, discrete med list. I can update our med list, and I don't have to plug those in one at a time. If the patient's been to 15 doctors and I got 14 different med lists and I have to reconcile them all, my doctors love that. That's really fun. Problems too is challenging, even though it maps to ICD. So we reconcile where we can. I wish we could auto-reconcile better. There are some new tools that allow us to do some reconciliation views for, particularly in the pop health world, where medications can be sort of auto-reconciled. If it's exact same med, same dose, same route, same frequency, it tells you, and you don't have to, it sort of just shows you kind of a conglomerated med list, which is great. So those are the things that we're trying to do to, again, make it easier.
Again, just that case that I talked about with the pediatric provider, primary care provider being more aware, and I'd echo the population health value that we're starting to use with it.
Hi. Can you compare and contrast differences and similarities between exchange through Carequality versus exchange through the eHealth exchange, if there are differences?
I don't think there's much difference. No.
No.
I think there's enough standards there that we're not seeing a lot of variability.
I just got to maintain 2 different certificates, X509
Yeah.
certificates. Otherwise,
Yeah.
That's the point.
Yeah.
If a CCD comes in, we process it. We try to put it through the same cheese grater.
Yeah.
Matt, you talked a little bit about how you and others have been engaged with your vendor to try to help inform their interoperability glide path, if you will. And I'm curious, from the Cerner side, is there a similar forum where providers who are using Cerner have a chance to get together and work with the vendor to kind of help set the agenda in terms of evolving functionality?
Oh, definitely. Same type thing. There's advisory committees and specific user groups around pop health and exchange, et cetera, and even pediatrics.
So I have to mention that Stephen Lane has worked with us in California and originated the concept of sort of doing comparative analysis of your configuration of your HIE tools, and created the famous Stephen Lane spreadsheet, which was everybody who was using Epic in California, we could look and see how you managed authentication processes. Were you querying automatically? Were you part of the eHealth exchange? And now the entire Epic network does that across the network. We can download a spreadsheet and see across 375 sites how they've configured their HIE tools, and then we can use that in a comparative way to improve our own individual configuration and success, or work in regional groups at state or regional levels, which are starting to happen. And I suspect that's happening in all of the implementers. So just like we're within the network and the implementer, the Epic implementer, sharing best practice, let's start thinking about sharing cross-implementer best practice. There's got to be ways to learn and leverage from that so that we all move forward faster.
I have another question. Payer requests for patient health information. How do you handle those?
Well, that's a whole other panel. We're not on the payer panel.
Come on, you're doing it somehow.
So there,
Our HIM department, handles those requests. I do know that we are looking at a new capability for life insurance companies to be able to use Care Everywhere, with Epic, to get electronic information readily. I think it's Gateway?
Yeah.
Yeah.
So our vendor is offering a payer gateway that
Payer
we have to
gateway.
figure out how to use that and leverage that. It's not live at our institution just
Right.
yet. We have individual relationships just like everybody else with payers for specific data.
Yeah.
I mean, obviously the payer use case, particularly in the population health world and sort of population health cohort queries, there's going to, that's just, I think, really
It's
taking
starting,
off. And that's going to be, and I'm sure the advisory council will bring that up sometime in the next couple of months. How do we manage it when you want to get 2,000 records every 2 months on a patients that are in a shared ACO?
Right.
So I'll add to that, I think, and I'll look at our Epic folks over here, because I think in 2018 they're offering payer connectivity through Care Everywhere, similar to Social Security. So for Social Security, for disability claims through the eHealth exchange, apparently it's supposed to work similar to that. I don't know if you can comment on that.
Why don't you can talk to Doyle later if you want. He's, yeah. See, you're going to go home and all you're going to think of is better Mob Rob.
Yeah, Mob Rob during the break. He'll talk your ear off. No, we've definitely heard the same use case that this discussion is covering, which is there's been a lot of success in treatment scenarios. There's still work to do, but there's a lot of success stories there. There are very valid use cases why we need to share this information with other scenarios. We've heard a lot over the last couple of days about sharing with individuals and giving them access to their information. And then this use case, which for payers, I think is both health payers as well as life insurance. And there was a panel a couple days ago that spoke a lot on that, and I think had really good points. So yes, as a vendor, we're looking at that. We've got some tools coming out shortly that will help there. I assume other vendors are as well. We're not the only ones. And I think that one of the great opportunities is similar how Carequality has brought governance and consistency to the treatment use cases. Are there opportunities to bring consistency to these other scenarios as well? Because I think that the entire community, the entire nation benefits when you have the same expectations and the same consistencies across different platforms. So yeah, we've got a lot of stuff coming, and I'm hopeful that this will be a venue where more improvements can come.
Yeah, I would just echo that, we started with HIE non-discrimination. We have a foundation and a framework. We have great, intelligent people who understand the technology, and we just need to build use case by use case.
I think it's an organization that's been most difficult with compliance and having them open up the possibilities of being able to exchange. I know when I go to my compliance team meetings, they cringe when I walk in the door because I want to be able to explain the benefits, but they just can't get past it. So I think someone talked about the 101. Here's the 101 page on interoperability. Read it over, and it seems like there's some changes that happen in organizations. So every time someone else comes in, I feel like I'm starting from scratch. So if there was just a level of, okay, this is where we're at, this is what we've done, this is where we want to go with the exchange, and just working with the compliance and security teams regularly, because we get it, we understand it, we've been there since conception, but a lot of them, especially in our organization, still struggle with the capability of sharing that information openly.
Yeah, SEMA Verma and CMS wants to axe the fax machine, although the fax machine is my favorite thing to go back to compliance and say, secure health information exchange is way better than the fax machine.
Right.
So we can beat the fax machine any day.
Yeah.
But, I think, for us to, Carequality is going to need to keep growing if we want to kill the fax machine.
Yeah.
Hi, I'm Adam Rabinowitz from, I support the DoD system with DMIX. So I think I'm piggybacking off of what you're saying, because one of our largest trading partners is the Social Security Administration. So I don't know if this is offered today, but the deferred patient discovery workflow for those partners that have coverage as their use case, I think I'm kind of piggybacking off of what you're talking about. But is that part of Carequality today? Or is it strictly the patient discovery, document query, document retrieve workflow?
So, do you want to say Dave, or do you want me to say Dave?
Yeah, I may actually need to even confirm with others, but I believe that there certainly is an asynchronous option for patient discovery, and I believe there are two different things. Doyle, do you know the asynchronous versus deferred are two different options? John's nodding, so. And I'm reasonably confident that both are permitted by the implementation guide, but not required. And as such, you can draw conclusions as to how likely they are to be supported. If that was something that we felt would made a lot of sense for the coverage type use cases, or for that matter, payer type use cases, we would probably look into enabling that and saying, hey, if you support the permitted purpose of payment, for example, or operations, then this is the way you do it, and it's not optional anymore. But that would be something we would have to obviously come together as a community and figure out, yeah, this is the way we want to approach that particular use case.
And if you like those kinds of conversations, join the advisory council if you're not already on it, because that's what we do.
One more question. So it seems from a Carequality perspective, you're accessing the sources directly. You're using them to go straight to the eClinical Works practice or the other hospital. Do you still see a value for aggregations like health information exchanges in your regions, or do you see you're getting more value by going straight to the source? Sort of a loaded question.
We looked at both models. We looked at regional HIEs. We have decided to go straight to the source. I would say it's difficult to maintain, but we did not see the purpose of joining a regional HIE at the time. We formed a clinical integrated network about 3 years ago. Looking back at it now, I wish we had gone the route of joining a regional HIE to get that information for different purposes, but not knowing where TEF is going to take us, we're kind of we're in a standstill in deciding where we need to go next. Do we need to just hold on with our direct connections, or join that regional HIE?
And we sometimes get it from both places, because we connect to, California is really kind of dispersed. There's lots of different, there's no statewide HIE yet in California, and certainly no California state mandated HIE. We connect to several of them through the eHealth Exchange. That was good for us when we didn't have the data. Now sometimes we'll get it now from a source and the exchange. Now remember, HIEs aggregate a CCD at the patient level. They kind of work differently, right? So you kind of get, it's not always exactly the same, and it also feeds into the challenges we have in terms of reconciliation.
Yeah, I would say just the way they act differently, they both have value. As far as Carequality, we're more on demand, where we're able to pull information from our HIE and then look at it as, basically not just demand.
Okay, so, the cybersecurity program is next, I think, right? We're doing, no. You know what, actually, for query for treatment, we have, the security around that, I think, is very comfortable. We're actually more challenged with fire security and third-party APIs, and have done a lot of work to assess the risks to our organization from a technical perspective. I got a chief information security officer who will, we put together, again, a white paper on what are the risks to us in opening third-party APIs. I mean, it was mandated, so we had to do it, but we also wanted to do a risk analysis. Frankly, I think that's going to be our biggest challenge, and we now have to start looking at security across web services and additional tools. You're all doing it, we're all doing it, we're all going to have to do it. And I agree with you that you can't do Exchange without thinking about cybersecurity, particularly with some of the new technologies. So we got to get over it, we got to start thinking about it, we got to start educating the government about those risks, because they can't say any API that the patient wants of their own selection without any education as to whether that's actually, coming from who knows where.
Yeah.
So those things are out there, and we will have lots more conversations about that.
Yeah. Agreed.
Okay. We're actually a little bit over, so thank you everyone for your feedback today. It's been a pleasure.
Yep.